I'd like to welcome you to the first webinar of 2021 from the Australian Dementia Network Memory Clinics Initiative. My name is Parminder Sachdev, and I'm co-chair of the Memory Clinic Initiative. I'm deputy chair of ADNeT. Today, we're going to hear about the development and function of the Cognitive Dementia and Memory Service in Victoria, the CDAMS as it is known. And our two presenters are Associate Professor Mark Yates and Elizabeth Rand, and I'll be introducing the speakers in a moment. Before that, I'd like to introduce the Australian Dementia Network to you. I'll just preface that by saying that today's webinar will be recorded, and this recording, along with recordings of previous webinars, will be available on the YouTube channel of ADNeT, and the web address is in front of you. Or you can go to the ADNeT website for this. Before we begin, I'd like to acknowledge the country custodians. The Australian Dementia Network acknowledges the traditional custodians of country throughout Australia and their continuing connection to land, sea, and community. So we pay our respects to all Aboriginal and Torres Strait Island people, their cultures, and to their elders, past, present, and emerging. Now, what is the Australian Dementia Network? Australian Dementia Network was funded through a grant of $18 million from the NHMRC, NNIDR, and a $2 million grant from philanthropy to develop a national network of researchers with expertise in dementia. And there were primarily three initiatives in this. The first initiative is to develop a clinical quality registry, which is a national registry that includes people from primary care services, aged care assessment teams, memory clinics. And in fact, it started work with memory clinics now and gradually will roll out to other sources of registry. The second initiative is what this seminar is about, the memory clinics. And the idea is to establish a national network of memory clinics to provide people seeking a dementia assessment with standardized clinical assessment and post-diagnostic care. And this, of course, will be linked to a number of other initiatives as we develop. And the third initiative is actually to develop a highly characterized standing trial-ready cohort of people at risk of developing dementia or in the early stages of dementia. Not only to chart the natural history of dementia, but to actually speed the development of new drugs by enrolling people in trials. And these three initiatives are supported by two other initiatives. One is the technology initiative, which supports the technology infrastructure of ADNeT. And other is a business branch, which is a kind of a slightly arm's length business limb, which interacts with industry and other donors so as to provide sustainability for ADNeT going into the future. Without further ado, let me introduce the two distinguished speakers for this. They've both been involved in the development of CDAMS clinics in Victoria, and we have, I think, a lot to learn from them. The first one is Associate Professor Mark Yates, who's the Interim Clinical Director, Aged Operations in the Ballarat Health Services. He's a physician in geriatric medicine in Ballarat Health Services and a medical lead for the Grampians Health CDAMS, as well as a medical lead for the Dementia Care in Hospitals program. Mark's previous appointments include Dean of Dean Medical School, Ballarat Campus, President of the AMA Victoria, as well as member of the Pharmaceutical Benefits Advisory Committee. And the other speaker is Elizabeth Rand, who is the manager of the Caulfield CDAMS in Victoria. She is an occupational therapist by training and completed a postgraduate diploma in neuroscience. She has had a strong involvement in early memory clinics since 1990. And with CDAMS from its inception in 1998. She held the position of chair of CDAMS coordinators group for several years, retiring from that position last year. She has sat in numerous steering and advisory committees at local, Victorian, and Commonwealth government levels, including currently sitting on both the ADNeT registry and memory clinic steering committees. She's a co-author of the book entitled After the Diagnosis, Living with Alzheimer's and Other Dementias.
Thank you, Pramila. Thank you very much. And I'd like to acknowledge Liz's work here. It's been extensive, and Liz will get to go second, but she's got the hard yards of detailing the way the CDAMS clinic runs. I felt that it was important, we both felt it was important, first of all, to provide some historical background to CDAMS. So we're going to provide the context around which the Cognitive Dementia Memory Service began, then provide you with Liz will then provide you with the details of the best practice guidelines and what leads that, and some data from her own clinic. And then we'll finish up with perhaps looking at what sort of ecosystem that you would need to think about in your own state to develop a CDAMS clinic. And I guess by saying that, I'm preempting the idea that I don't know that the federal government's going to come up with the funding. I think each jurisdiction is. So just where we've come from when we have all this discussion, there's been a lot of water under the bridge. It was back in 1997. It seems an awfully long time ago now that Dementia Care in Victoria, Building Pathways to Excellence, was released by the government after a long consultation, which actually began in about 1995. There was a review in 2003, and then CDAMS was formally formed after and strongly funded after that particular time. Just mentioning quickly that there was we had the process. Then there's the Minister's Dementia Advisory Group, Dementia as a National Health Priority in 2010. There's the framework, the National Frameworks on Action for Dementia, the Dementia Services Pathway developed by KPMG, which I mentioned later, and more recently we've had the work of ADNeT, NDIR, and then really ADNeT has been the sort of next progression, I would imagine, from the NDIR. So Liz, if you then go to, that's the one. Thank you very much. The Dementia Task Force itself, as I said, 95 to 97, it had 44 recommendations addressing the whole dementia pathway. Next slide. And I think this is important to highlight, and you'll find that we'll both highlight this during our talk, that in fact, CDAMS as a clinic and as a service actually gets people started on the pathway, and that pathway is certainly at the point of diagnosis, but we acknowledge that the pathway starts with older people, the emergence of early difficulties, which I tend to call the inkling, which is that MCI type period, and then when significant difficulties emerge, and that's when functional change and definable major neurocognitive decline occurs, and then reduced capacity, high dependence on care, and then incapacity. So that's one description of pathways, and that was back in 1997 that was published. Interestingly, KPMG in 2011, some 14 years later, actually had a very similar pathway as far as patients and families were concerned. And I think this just highlights the reality of dementia, sadly, that in fact, neurodegeneration, when it's occurring, is really just a process of neurodegeneration. So people don't get better generally. Now, maybe the serving aid makers like to think that we may stop that neurodegeneration, but I'm not sure we will. And so far, we haven't achieved medications that actually get people better, but we will hopefully stop the decline. And so not only is there a pathway for the patients, but KPMG, and I refer to this, quite a useful document, talked about where policy and planning and where we are as CDAMS is this initial assessment, diagnosis, and to a degree, post-diagnostic support. So that's where CDAMS fits, and again, highlighting the fact that it really needs to be part of a larger development of a pathway. So I think if we're going to talk about CDAMS, we need to realise that we're not developing the entire dementia pathway. So one of the things that drove this question about why do we need CDAMS was because there was a sense, and there's still an agreement, I think, widely, that early diagnosis, or maybe better determined as timely diagnosis, is a very important part of good care. And from my perspective, I think you can imagine and argue but early diagnosis is important on the basis of the needs of the patient, the carers, and also the healthcare delivery system. So there's no doubt when you see people with dementia, that while they don't necessarily like the first idea that they've got dementia and it's difficult for them, but when properly delivered and the diagnosis is properly delivered, then it can be done without undue stress, although there will be some anxiety. But it does in the end mean that they make sense of what they're experiencing, and many patients will come back and say, I'm so glad I understand what's going on. It does give an opportunity for control, so the sooner we can make a diagnosis, the more likely people can choose who their enduring powers of attorney are, what they want to do, what's on their bucket list, and it also maximises the opportunity for prevention and treatments, particularly thinking about the vascular group. It supports carers. Numerous times we'll see families at odds with each other, fighting with each other about what's wrong or what's not wrong with mum or dad, and this helps give them some diagnosis to work with and begin to get their head around, as well as their access to education and services, and it refines healthcare delivery. So, for instance, it's important when patients go into hospital, as we know, if they've already been seen in a CDAMS clinic, that they are alert to the fact that delirium is quite a likely outcome and share that with the health system that they're working with. In primary care, very important for chronic disease management, for people to understand they've got a dementia well before it causes problems with their diabetes management, for instance. So it was this concept that there needed to be early diagnosis. And in Victoria, when back in 1995, there was no organised service. Dementia was diagnosed in some research clinics by the odd neurologist. It was maybe thought of by a geriatrician in hospital and in outpatients, but there was nowhere where someone was putting up their hand and say, look, come and see this clinic because we'll deal with the diagnosis. And early on, we heard from primary care that they didn't want to get into this because what do they do with the problem? They knew if someone was breathless, they could send them to a respiratory physician or a cardiologist. But if someone had a memory problem, where do they go? And there was no organised service. So CDAMS initially was there to be an accessible, multidisciplinary specialist service providing early diagnosis, advice, support and referral for people with cognitive difficulties. That was the key. That was the key to what we were trying to achieve. And the reason it had to be accessible is because it needed to address regions, but accessible also to primary care, so that when a GP did find someone who had a problem with memory and thinking, that they knew where to go, so that they didn't get just brushed under the carpet as a problem of older age. Look at the next slide. So then, what do we do? And this probably just further emphasises some of the aspects of this. Multidisciplinary services is very important. It's not a service that's just about a medical diagnosis. It builds in all the other allied health components. We've talked about timely assessment and early diagnosis. Advice, support and referral is important. I have my own brain analogy of the dementia pathway as a railway track around which there are a variety number of stations, but we do know people are on the track, and when they're on the track they're not going to get off it, but how often and what stations they get to are fairly understandable. When and how and in what order may be a bit different, but ultimately that advice, support and referral is important. Consultancy, education and support, and then short-term assistance. In other words, let's make sure all four wheels are on the railway track properly, and that there's not too much wobble, and you know where you're going. And but one of the early iterations of the CDAMS, I'll show you later, but that had the word management in it, and that got taken out. Next slide. So it's state funded. There are 9 regions, and there are clinics, multiple clinics in some metropolitan and multiple in rural. And in my region, which is the Grampians region, there's a clinic in Ballarat, a clinic in Horsham, and there are also 2 clinics in the southwestern region of Victoria, Geelong and in Portland. So there are a variety of spots to ensure that accessibility. And more recently, CDAMS has been drawn in under what's called the health independence programs. This has actually, I don't think, been the best for CDAMS. We now have to fight for our funding from all the other sorts of independence needs. So that's been a challenge for us. So pain, wounds, continence, community rehabilitation forms, movement disorders and cardiac disorders, cardiac rehabilitation and respiratory rehabilitation have all been mixed in. And so we have to now justify our existence, which is difficult for a low frequency, long, complex clinic, as opposed to many of the health independent services are all high frequency, short contact. Going to see the physio to have my, fix up my by walking, or I want a continence referral, and it's going to see the continence nurse. So the other core principles, having talked about the core objectives of the service, are that we maintain a person and family-centred view. There is we seek active consent from the participants, that's both the patient and their family, to share information, because we're doing a lot of referral and shared information across systems, both funded by federal and state, so primary care and hospitals. Care continuity and service integration. One of the insistences, there is a secretary for CDAMS, and when they answer the phone, they say, "Hello, this is the CDAMS clinic," not that, and they try and make sure they've got access to patient numbers and names. And it's evidence-based and a quality service. The core staff, there's a medical core staff, and you'll see that GPs are part of the core staff. In some rural areas, GPs are what's available, and a GP who's got sufficient interest and training to identify and investigate cognitive problems in the main can do a very satisfactory job, and particularly if they're supported then by geriatricians, neurologists or psychiatrists. We hope to have at least a psychiatrist and a geriatrician or neurologist in every clinic. That's not been achieved. Almost all clinics will have a geriatrician, and some will have then a mixture of the other services. My clinic at the moment has one neurologist and myself in it. Allied health, neuropsychology. Neuropsychology is a critical and a part of the CDAMS clinics. In my clinic, we're about 40% of all our patients are referred to neuropsychology. And then we go on to, so then having said that, so then moving on to, so we're back, my slides advanced by accident. So we've got an integrated early diagnostic service. So this was the earliest iteration of where we thought CDAMS would sit. Back in '95, ACASs were still very much a clinical system, and our psychogeriatric assessment teams were active. And in that time, we were called the Cognitive Assessment and Dementia Management Service. The management got taken out, and it's got called Cognitive Dementia and Management Service. This is where we would have sat it, and it's just this concept that integration is important. Then the last slide there is really this concept which I've been highlighting around integration. The next slide, Liz. So that's about the strong connection between service providers to reduce duplication, ensure integration, and assist with service development and awareness. So we were doing a lot of service development. We were educators in the state around dementia and dementia services in the whole pathway, and we enabled CDAMS service to manage incident demand. So it is about the incident cases, not the prevalent cases, and I think that's where you want to look at your data. If you go to prevalent cases, you'll find your governments will turn around and say, well, it has to be too big. But work on incident cases, and then you might be somewhere there. I think at this point I need to hand over to Liz.
Great, thank you, Mark. So I'm going to pick up from there and talk a bit more about the history, and then a bit more about how we actually operationalise the model. When the Dementia Task Force recommended CDAMS, and it was initially set up back in 1998, we had a number of key deliverables that were set for us based on the principles that Mark has been talking about. So one of those was on service linkage and integration, as Mark was just saying, and it's a central principle to CDAMS in that we're set up to develop with those, to work with those new incident cases. So they set up a number of different deliverables and KPIs to manage to capture those around, in terms of linkage, around identifying what they were calling the principal clinical advisor, otherwise known as the GP in most cases. And the KPI around that was to do that within 3 days of provision of and to provide provision of assessment reports to them in 80% of cases. So there was a strong emphasis on that linkage. Oh, went too far. Then there was some deliverables around it being an accessible service and timely. So they set KPIs around responding to referrals within 3 days, providing an initial home visit within 20 days, or 20 working days for 90% of clients, and completion of the whole assessment process within 50 working days for at least 80% of clients. These were very admirable standards to try and achieve, and proved quite difficult in many cases, but nevertheless there was a firm commitment to trying to achieve them. And so that led to a continual refinement of processes, and actually I think it helped us in our gradual increase of funding as well. There were some key deliverables around assessment as well, in that it needed to be a multidisciplinary service with a minimum standard of 80% of clients getting an initial home visit, and also a medical assessment. And they sort of gave some clarity around what those might look like. In terms of the assessment, they required that 80% of assessments included a multidisciplinary team evaluation and feedback session. So it wasn't set up as a sort of single discipline type arrangement. They were expecting that everyone got that comprehensive multidisciplinary sort of approach. There was measurements of the number of new contacts, identification of linkage to carers, and how much counselling and support was given along the pathway as well. There was also some fairly ambitious targets set around accuracy of diagnosis, including that about 20% of people, of people diagnosed with the early stages of dementia were reassessed to confirm that we had the diagnosis correct. In reality, that was rarely achieved, and still rarely is, I believe, due to the demand for new assessments. Having said that, those with MCI or those where the diagnosis is a bit dubious or not quite clear, then they are tending to be reviewed. There was also a very ambitious target of getting post-mortem follow-up for people as well, and that's been very hard to achieve. And lastly, there was some deliverables around the use of neuroimaging and ensuring that appropriate neuroimaging had been done within a relevant time frame. You may remember we mentioned about public visibility in our original role of CDAMS, and there were deliverables set around that in terms of information sharing with other health professionals, other services and the community. In the early days of CDAMS, we were very active in promoting the understanding of dementia, the availability of services and supports, including our own, as well as information about brain health and risk reduction, with teams presenting to local community groups, setting up displays during Dementia Awareness Week and attending professional conferences, etc. We're also quite heavily involved in providing education through the GP division of practices, etc., to upskill GPs to be involved in this whole process and along the pathway. The CDAMS, the Victorian Government funded a review, as Mark mentioned, of CDAMS in 2003, and overall the model was endorsed. However, it was noted that there was some variation between services as to how it was being implemented. So they recommended that guidelines to be developed to improve consistency across the state. There wasn't any funding for that work, but we established a working party of CDAMS coordinators and other people to develop those. and it was a very enthusiastic team, but it did take a while to do. You can see it took 3 years for us to get there. It was a very rigorous process that was undertaken, first of all, to review the literature, to look at memory clinic models internationally, to review all the relevant governmental policies and guidelines and the deliverables that have been recommended in the Dementia Care Victoria Pathway to Excellence report that Mark mentioned, and also to look at it in the context of the national safety and quality standards for hospitals and best practice guidelines that have been developed by other services. So we had extensive consultation with internal and external stakeholders, and also with all the CDAMS teams to develop the guidelines and then reach a consensus. The process was quite challenging because, as you know, best practice guidelines can be hard to achieve realistically within available funding and staffing. However, you know, they are the gold standard and what we need to try and achieve and work towards. And they were eventually agreed upon by all of the teams. In 2013, the government funded a review of those initial guidelines to ensure that they continued to reflect current evidence and best practice. They did fund a project worker from the Faculty of Psychiatry of Old Age in Melbourne Uni to lead that review, and she completed an extensive review and update of the literature, further internal external stakeholder discussions and surveys, and we had quite a number of workshops again with all the CDAMS teams to reach a consensus. In effect, and perhaps pleasingly, there was minimal change from the original guidelines, and I thought that was reflective of the foresight of the original concepts in the formation of CDAMS back in 1999 and the work that was done subsequently by the coordinators group. The guidelines are available at that web address that's listed on the screen, which is at the Department of Health, and also the literature review is there too, if anyone's got any interest in those. The best practice guidelines include 16 standards, and 9 of those relate to the process of assessment, diagnosis and care, 2 to care coordination, 1 to leadership and management, 2 to team competency and training, and 1 to quality improvement. While specific guidelines for cold communities, family and carers were in the initial guidelines, further standards around the ATSI population, intellectual disability and young onset dementia were added to the 2013 guidelines. Each standard has a definition, criteria that need to be met for that standard, and guidelines on how to do that. I just wanted to mention the role of the clinical coordinators group within CDAMS, because it's been very crucial to the development not only of these guidelines, but the development, advocacy and expansion of the service as well. The coordinators are clinicians in the main, so they work in a clinical and a coordinating role, so they have a hands-on knowledge of what's involved in the clinic. They have quarterly meetings, and they've been held since the inception of CDAMS, and they've established various working parties to work on different issues or needs as they've emerged, so that we can have a very collaborative, collegiate sort of approach. So they've been the driving force behind the development of those guidelines and how the CDAMS model has evolved. The group's been very active in consultation, liaison and advice to government at both a state and Commonwealth level over the years, and have frequently responded to advice and support for steering committees for other service providers such as Dementia Australia and Bolton Clark, the old ADNeT, etc. We were commissioned to provide education to ACAS teams across the state in the recognition, assessment and management of dementia as well. There's also been strong collaboration between teams with a community of practice approach to support each other. We have biannual CDAMS education days, and we've had those since the inception of the service, with expert speakers on emerging topics and trends, as well as workshops for staff to get together and discuss innovations and issues, with the aim of improving services, but also trying to maintain some consistency around the service delivery. Oh, and we have an email discussion group that's very productive as well in between times. So moving on to our CDAMS model of care, which I'm going to walk you through fairly quickly. The way the model flows or is operationalised may vary slightly from team to team, depending on its location, whether it's metro or rural, the team size, their staffing and specialty, etc. However, the basic principles of the practice remain the same. So the first stage, of course, the first stop along the train, as Mark would say, is the referral process. When CDAMS was first set up, it was recommended that referrals be accepted from anyone, including family and clients themselves. So we don't necessarily need a GP referral. And that was because at the time there was a feeling, as Mark mentioned, I think, that there was low recognition and response by GPs to complaints about memory in practice because there wasn't much they could do about it. So therefore, a GP referral wasn't mandatory to be accepted into a CDAMS. However, a GP referral is always preferred, and we actively seek to engage GPs in the process with the client's consent, as they remain central to the whole model of how a person's ongoing management is done throughout their pathway. In reality, these days, the majority of referrals do actually come from GPs anyway. In Victoria, the introduction of the Better Care of Older People and Health Independence guidelines that Mark mentioned required health services to have a single point of access for all of those community and ambulatory services, and a one-stop shop for referral inquiries, initial needs, identification and triage. As a CDAMS, this means we've done and continue to provide education to those access teams to ensure that they have good understanding of our service and what we can potentially offer people and our role, so that the triage is as appropriate as possible. The role of the access unit is to complete an initial needs assessment to decide whether the referral is suitable for the service, and also whether other services may also be appropriate for that client. And they set a priority of access as well, which is then reviewed once they get to the CDAMS. Once referral is accepted into the service, clients are allocated to a key worker who does the initial assessment. In the initial setup of CDAMS, it was recommended that be a home visit, but in practicality, particularly for the rural teams, that's quite challenging. So in most services these days, it is a clinic visit. In our particular visit, I'm an OT by background, so I prefer home visits, and where it's necessary, people still do home visits, particularly if there's no reliable informant, and we're going to get a lot more information from seeing people in their own setting. The purpose of the visit is multifactorial. First of all, it's to set the scene by explaining the service, what they can expect, and getting their consent to proceed. Time is usually spent gaining an understanding of what the client and family know about memory loss and its causes, what their expectations are of the service, and what outcomes they are wanting or seeking. We generally provide a bit of education on how memory works and what causes some changes. And the reason for that is so that we don't get to the final feedback meeting and realise that they've never even thought they might have dementia, and we're about to tell them that they do. So doing that sort of baseline information gathering and discussion is crucial in forming how we proceed with the assessment, and particularly with the feedback and diagnosis at the end. The key worker remains the central point of contact for the client and family throughout their time with CDAMS, and is usually responsible for responding to queries, arranging any referrals, and follow-up at the end as well. In addition to all of that, the initial assessment includes a detailed history of the presenting complaint, their medical and psych history. We get details of their social, cultural, educational and occupational history, which is necessary for interpreting results. We do an assessment of their ADL function. That may be a direct assessment in someone we don't have an informant for, or it may be an informant history to get an idea of their ADL function. We assess their mood, cognition and carer burden with screening assessments. We start discussions about driving and enduring powers of attorney, advanced care plans, etc. If there's any immediate support needs identified at that stage, relevant referrals are made. The client would then proceed to a medical assessment normally, and that's usually done in a clinic. Mark might be able to correct me, but I don't think there's any clinics that do the medical assessment out in the community, but it may be done by telehealth. That assessment builds on the information that's been gained at the initial assessment. It includes a comprehensive physical and neurological examination, assessment of their behaviour and psychological symptoms, and a range of cognitive assessments or standardised cognitive assessments. The tools that different clinicians use will vary from team to team, but all will use validated standardised assessments. Biomarkers are also arranged. We do a full pathology screen and imaging. The majority of people that come to CDAMS these days, certainly in our clinic, do come with a CT brain and dementia screen already done, but we may also request an MRI and in some cases functional imaging, FGG PET scans, and some of our clients will go onto the ADNeT imaging for amyloid PET. Lumbar puncture and genetic testing is not frequently done, but occasionally would be done so. In terms of neuropsychology, only those that require detailed assessment after all of that other assessment has been completed go on to have neuropsychology. In our particular clinic here at Caulfield, we have a high percentage of clients that do actually have neuropsychology, and it's about 75% of our clients actually do. And that's because we have a very highly educated, tertiary educated client cohort in our catchment area, and they're presenting very early in their disease pathway, so they frequently need that higher level of assessment. Our neuropsychologists take a hypothesis testing approach which builds on the other assessments that have already been done. Following all of that, we gather together as a team and then meet to come up with a consensus diagnosis. And everyone that's seen the client in our expectations and guidelines is that everyone that's seen the client will participate in this multidisciplinary case conference to reach that consensus diagnosis. We then formulate a care plan looking at all those factors, so pharmacological and non-pharmacological management, risk management, brain health sort of information, what support service needs and referrals might be needed, what information and education needs we can address. We look at their driving, whether we need to provide information and advice on future planning, and whether they're going to need a further review if they've got mild cognitive impairment or their diagnosis is somewhat unclear. We then proceed on to a feedback meeting with the client and with their consent, their family or carers. We strongly encourage family involvement throughout the CDAMS process, and we're very reluctant to give a dementia diagnosis if family aren't available or involved. So we work very hard to get the family involved. In that family meeting, we discuss the results of the assessment fairly briefly, and then we talk about the diagnosis and prognosis. We're very clear in our diagnosis, so we will label what we think the diagnosis is rather than being a bit vague. We discuss the recommended care plan and get agreement on any referrals that are required. We also spend quite a bit of time dealing with issues around driving and the need for assessment, and around future planning, such as enduring powers of attorney and advanced care plans. And those two last things can be quite challenging to discuss. More recently, we've started participating in the ADNeT registry, so we talk about that and gain indication of whether people are interested in research. And that's a lot of information to convey in one particular setting, and it can be quite overwhelming. So at times, sometimes that needs to be broken down, and we might do some of it in one meeting and some of it in a subsequent meeting. As Mark said, we do provide some short-term follow-up, but not ongoing case management. The purpose of the follow-up is to check on the person's understanding and response to the diagnosis and provide support around that. Some, but not all, clinics provide prescription for cholinesterase inhibitor, whilst others get the GP to do that. And those that do prescribe provide short-term follow-up until continuation of the authority script. We make sure that people are linked into services and the referrals are followed up on if they've been agreed to, and that we can follow up with strategies for support and manage to improve their quality, and management strategies to improve their quality of life. Where possible, we aim to pass people onto the dementia care pathway if a diagnosis is made, so that they can continue to receive the support and advice they need, not necessarily from us, but from that pathway. However, CDAMS does remain available for phone advice and support as needed. For those that don't get a diagnosis of dementia, when they have either diagnosis of MCI or their diagnosis is unclear, they would be reassessed in 12 to 18 months, depending on the situation and their presentation, and they continue to be reassessed until there's some sort of clarity reached. So that's basically our model. I just wanted to show you some data that we've got from the CDAMS here at Caulfield. In the very early days, we actually started our clinic back in 1990. And so we've got quite a bit of data. As you can see, in more recent times, people are presenting very early in their symptom progression, so commonly within 1 to 2 years of their symptoms being recognised by either them or their family. And also, as reflected in these MMSE scores, you'll see that they've been sort of increasing gradually over time. When we first started back in our clinic in 1990, our average mini-mental was sort of round about the 21, 22 mark. Now it's getting average over about 26, with the majority of people being quite high these days. Our diagnostic trends have changed as well. In the very early days, people presented with well-advanced symptoms and diagnosis was typically in the moderate stages of dementia. And then you'll see when in the early 2000s, when the cholinesterase inhibitors starting to become involved, there was increased awareness and hope for treatment, and that resulted in people seeking assessment and access to treatment earlier. So our diagnosis of MCI and subjective cognitive impairment started to trend up and has continued to trend up. And you can see the dementia diagnosis is on a downhill slide, and the subjective cognitive impairment and MCI is on a significant uphill trend over those years. That doesn't necessarily mean that we're getting worse at diagnosing dementia. What we've done is, I think we've become much better at targeting those that come through the clinic, to those that do need that high level multidisciplinary approach. And we've worked very collaboratively with other services, in our particular instance with our geriatric clinic, so that people are triaged appropriately, so they can be seen in the most appropriate venue, and not because not everybody needs the detailed CDAMS sort of approach.
So I think just briefly, we've gone. I want to have time for some questions. I've been answering a few questions as Liz has been going as well. So I just wanted to try and then frame, the concept of building national networks of CDAMS clinics or memory clinics, and we've just said diagnosis and initial support services for cognitive decline. Just so you can all choose your own acronym if you want. And we know that cognitive dementia and memory service was a very bad acronym because it didn't meet English language standards, because it should be cognition rather than cognition, dementia and memory service. However, at the time that this was formulated, the ecosystem in Victoria was, as I said, one of a fragmented service for cognition. You were lucky if you could find a neurologist or a geriatrician who might have been interested. Certainly you couldn't do anything in the regions and the country. So it didn't support primary care. And I think that even now in the Australian context, we still have a process around the diagnosis of dementia which doesn't support primary care to engage. And it doesn't support primary care to engage if there's nowhere to take the problem when you identify it. So I think that's very important. The downside of that is around then this question of incidence cases versus prevalent cases. And I think the data from Caulfield that Liz presented was very interesting. The MCI diagnosis going up and the dementia diagnosis going down. And that would suggest to me that in the Caulfield region, at least, they're building a system where the prevalent cases, those who have been left somehow not being picked up early enough and have then got progressive and significant dementia who aren't hard to diagnose. If someone's got an MSE score of 15 and they're perfectly hale and hearty, and the family can tell you that they stopped doing the banking 2 years ago and they stopped driving at the same time, and now they don't prepare any meals, and it's just been a gradual change, but they've looked after mum at home and they've been very happy with that, then it's pretty obvious to make a diagnosis of dementia. So what I guess this is the system is about what you've got, and some of the chat's been about the availability of nurse practitioners, for instance, and they're a resource that is sometimes more available in other states than others, and clearly in Adelaide it obviously seems like there's a pretty good bevy of nurse practitioners who may be able to be part of the development of the service. So I guess when we talk about that, you've got to think about what resources you've got available, and then make sure that what you do is you don't reinvent the entire system just for people with dementia. Remembering that dementia is a condition that affects every other condition in the healthcare system. So unlike, for instance, diabetes, if you've got diabetes, you're not necessarily going to necessarily impact on the digestive system. And someone's going to tell me I'm wrong because there'll be autonomic neuropathies, etc. But try to bear with me in my not so useful analogy. So if you want to build a service, you'll scare the living daylights out of government if you talk about the prevalent numbers, but you've got more chance of finding an argument if you talk about the incident numbers. So use your data to drive health change to make a difference. Next slide, Liz. So again, I guess we're going to highlight this concept of service integration, and we've banged on about this a lot, but I think that what you're beginning to, hopefully you're getting the idea that when you build a service, a network of a diagnosis, initial support service, don't reinvent all the other services, but use that service developed to fill in the gap that there's been a crying problem that been for people with dementia and their families saying, we don't know where to go because nobody takes responsibility. Next slide. So I think that to have your look for your statewide service, you want to argue around this concept of the organised approach to dementia diagnosis, to be able to argue a consistency of service. And so the guidelines that we've produced would be a good starting point. I'm sure you'll want to modify those to the context of your service. And you need to develop peer support in the development for and sustainability of the service. So from that I mean the dementia work, the dementia coordinators group, which began really, and it was Leon in the chat just mentioned the doyens of the CDAMS, Eddie Chu himself at Mount Royal Ages a long time ago, who really started that with the focus groups. And then once we got the CDAMS going, we said we want to keep this focus group going. So we brought the coordinators together. And that peer support meant that as each jurisdiction and then each hospital picked up the service, then there was a way to build consistency. So that is an important part of your establishing your pathway to developing a statewide service. Next slide then, Liz, if we could. So then the question is, where are your stakeholders? And then there are those government and specialist societies, and I won't dwell on that. And so just before we go to questions, in conclusion then, we've had a long history of memory clinics. They did begin in the 1980s, and then CDAMS got going. It has now well-developed best practice guidelines that meets the needs of both metro and rural regions. And it's the entry point to the dementia pathway supported and supports the whole pathway, that everything the pathway has to offer. So we'll take questions.
I think a number of questions have come up, and Mark, you've addressed some of those online as well, but I can see two main issues here in terms of the questions people have raised. One is which disciplines should be involved, and I guess in that sense, which disciplines should be integral to the clinic and which should be disciplines where you can outsource the services. So what is your general view on this?
My view, I think we see 3 or 4 key things. You've got to have a secretary, believe it or not, to make it all work. And so there's a voice at the end of the phone, because some clinics are less than full time. You've got to have medical, and that medical needs to be, if you can, at least one with a psychiatric interest and one with a medical neurology geriatrician interest. And if you can't, you'll get general practice. You need neuropsychology for sure. And then you need some component of allied health. Liz is an OT, we've got an OT in our clinic, and we source the rest by referral into our community rehabilitation service. And OT driving assessment, obviously, would be the other component, would be very helpful. Okay. I don't know, Liz.
And I think, nurse practitioner, you've already addressed that issue, I guess, in terms of, because maybe that's availability in certain places. Certainly it'd be great to have a nurse practitioner involved, just as a social worker, I guess, in some clinics have integral members.
So the nurse is critical, but we just don't use nurse practitioners. We use nurses with who have trained up and who have a particular interest in dementia, but they wouldn't have had to have gone through the whole process of a nurse practitioner course for 4 years. And then principally because prescribing is not really a large part of the service in CDAMS. It's actually system and service integration. There's a lot of that.
Yeah. Okay. So no, that's great. Now the other side to it is the post-diagnostic care, and I saw Liz saying that okay, you develop a plan, a care plan. See, all these are the services, these are the needs of the individual, and how do the needs match the services, and then you provide feedback. But how do you ascertain that this is followed through? Who basically makes sure that your 6 or 7 or whatever recommendations have really been translated as far as the patient is concerned?
Well, that's part of the short-term follow-up, and it would usually be the role of the key worker to do that. They would generally be responsible for doing some follow-up phone calls, checking on whether the referrals have occurred, whether they're suitable, etc. Yeah. But that can be fairly limited in our capacity to do that because of the workload and demand. Some services have set up other pathways for that. So, for example, in our particular clinic, we've done some work with the Alfred Carer Services, and they have a phone outreach program, and so we can link people into that who will then. It's particularly designed for those people that aren't quite ready to take the step to engage with services, and so they get regular phone calls at a period, agreed to by them, to see how they're going, whether the referrals have happened or whether they're ready for referrals, provide them with advice and information as time goes on.
Okay, and can I ask if this key worker is integral part of your clinic, or?
Yeah, it's the person that does the initial home visit. So it'll be the nurse or the OT or social worker or whoever those sort of home visit type people are.
Oh, okay. And I suppose the other issue is in terms of post-diagnostic care. And I was just wondering, you haven't actually taken on any of the care responsibilities, and I can see the message that you were giving, Mark, that integrate these services. There are all these services around you that you try to make use of those services. But how do you think that's working out, really? Do you think your patients are getting good post-diagnostic care?
On the whole, yes.
Okay.
And I think, Raminda, they are. That varies with service, and it depends how post we mean by post-diagnostic. I think that you could build an entire health service knowing that the average survival post-diagnosis is about 8 years. How do you build a service that provides care ongoing? But I do think that the key worker role is important, and I think we set people up, and we then have to make sure the rest of all the other stations are properly furbished so that the patients and their family can know that they're there and they're coming, but also then can get access to them. But I don't think a single clinic can actually do all of that without it being, it'll become the entire healthcare system. And if you want to put the argument up to government, the way to scare them is to say you're going to provide a management service for 8 years for patients, because they're not going to go for that.
Sure. Okay, a couple of other questions come. Chris Rowe asks, how many new patients are seen in CDAMS per year? Is there a figure?
Well, Mark, you might want to answer that, but generally it will vary from clinic to clinic depending on how much funding they have and the size of the clinic. We used to get data from the Department of Health, but they've been a bit reticent with that lately. Our particular clinic, we'd see about 300 new patients in a year. We're funded as a sort of 1.5 day a week clinic.
Okay. But you don't have overall Victoria-wide figures? I
don't know.
Okay.
So we see about 50% of my patients are new. If we would accept the fact that a new patient is someone who's being reviewed after 1 year, we discharge the vast majority of our patients within about 6 months of when they're seen in the clinic, by which time we would have established the diagnosis and care plan, and they know where they're going.
Okay. And this final question before we move on to, we have a couple of short video presentations after this, before we finish. So I just get this question. Michelle Kelly asked about dementia care pathways. That you said you referred to dementia care pathways. She wants to know, what are these? Are you referring to Dementia Australia and home care services, or is this something else?
It's individualised according to what the patient needs, because there's no one pathway that people are going to necessarily follow. Yes. However, there are some common sort of pathways, and Dementia Australia would be one of those, and that's we regularly refer to Dementia Australia. Having said that, not everyone's ready to engage with Dementia Australia to start off with, but we do encourage it and refer people on, particularly to what we're about to hear about, the post-diagnostic support, but they're living with dementia programs and things like that. We would typically link carers in with carer support services, and one of the issues we have in our clinic is because people are presenting so early, they're still living reasonably independently in the community, and they're not ready for engaging with my aged care and home care services, etc. So that can be a bit of a challenge in providing them with enough information to do that if and when they're ready, because they may not be in our service by that time. So they'd be the sort of main key pathway linkages that people would be passed on to. There was a comment in there about rehab, and this has been a bone of contention for me for a long time, that people with mild cognitive impairment certainly, but also in the very early stages of dementia, should get access to rehab. And it's extremely challenging to convince community rehab services, funded community rehab services, to take them on by virtue of the fact that they don't think they can learn. So it's battle I continue to have, and I'm having some success these days with our community rehab service only for people with mild cognitive impairment, but I'm working on the community health service to start doing a rehab type approach with some of our early dementias as well. But, you know, Dementia Australia can pick up some of that work, and I think we'll hear from Emma later on that that's some of the stuff they're going to do with the post-diagnostic support.
So that's a great point to transition to Emma, in fact. But I want to thank you both for an excellent talk, and congratulations on the work that you've done over 3 decades. So now we'll move on to a video presentation by Emma Craig on post-diagnostic support program of the Dementia Australia.
Thanks very much for inviting me to attend your meeting. I certainly can concur with what Liz and Mark were both saying, in that there is a variety of pathways for an individual to go down. It does, however, create a lot of confusion for clients and carers about what pathway, how do they access help, and our post-diagnostic support program is really just one of those pathways that someone might choose. So many of you may be aware, but Dementia Australia have been around for a significant amount of time. We exist to support and empower an estimated 500,000 people who are living with dementia, and also the 1.6 million people that are involved in their care. Our role is not only as a service provider, which is the area in which I head up, but we're also the national peak body for dementia in Australia. We provide source of trusted information, education and support services, and we advocate both systemically and to government around positive change for people living with dementia, and advocate for the rights of the individual. So we support a whole range of people involved in the care of someone living with dementia. Obviously the individual that might be living with dementia or MCI, as Liz and Mark both talked about earlier on. We support people that haven't received a formal diagnosis right through the whole lifespan of their journey. We support the family and the carers of people living with dementia, because evidence shows the significant improvement in outcomes and quality of life when you're supporting that whole family unit as well as their support network. We work with a large number of not-for-profits and volunteers and community organisations talking about dementia-friendly communities, talking about best practice, best design around supporting individuals, and obviously for the community to raise general awareness about what dementia is and how you might support someone. Our post-diagnostic support program is funded from the National Dementia Support Program, and this is a new program which we started in July of last year. It was based on the Alzheimer's Scotland model, and it was found that the benefit of obtaining a dementia diagnosis earlier rather than later is really the overall goal, and that people who are diagnosed earlier get timely access to good quality post-diagnostic support, as Mark referred to in his presentation. So the purpose of our program is really to support provide a model that provides time-limited, tailored, one-to-one support, kind of like the key worker principle that I heard earlier on, that we provide information and support for someone who's recently diagnosed, but also for their carers and families through a single point of contact. Our approach is that every person's experience with dementia is unique and their experience is quite different. Our program is person-centred and it considers all geographic locations, social situations and an individual's culture. And the services delivery is tailored to what best meets the needs of the individual. It really is about working with the individual and looking at goal setting and goal identification. What are the key objectives? What is someone wanting to come and achieve? What are their key issues? And working with an individual and really working from a strengths-based model. So how do we support that person and empower them? We support them by providing a whole range of information, including improving their understanding of dementia. We help them navigate and plan supports and establish their support network. And we really understand, you know, the whole idea of not recreating, you know, something is link them into already existing supports in their own community, but also, you know, really work across that multidisciplinary platform. Build the individual's capacity, both the person with dementia and the carer, and that is a whole significant piece of work that we're involved in terms of building them to advocate for the rights of the person living with dementia, but also looking at the strengths-based focus and not what the deficit of the disease causes. Engaging in mainstream services and maybe what we find at Dementia Australia, we're often getting people quite late in the diagnostic process. So we are probably having to help the individual to straddle all three systems of My Aged Care, NDIS or the Carer Gateway. So it's really being able to support them about what their individual goals are, where they need to go to access supports and how we might better support them through that. And prepare and plan for those key transition points. Very much like what we talked about earlier around, you know, the power of attorney, the transition to aged care, the whole grief and loss around change that the disease causes, and a whole range of aspects. The way we support people is really on an individual basis. It's not whilst there is structure to the program, it really is identified around what that person's needs are. So what do we know about who's currently enrolled? So at the moment we have about 51% of the people involved are the person with dementia. That is not to say that the carer can't be involved. They absolutely can be involved in those sessions as well. But we're also finding about 40% of the people who are involved are the primary carer or a family and friend, which makes up about 9%, and those people who are inquiring about a memory or concerned about a memory is just a small amount. So how do people refer to PDS? Much like many other not-for-profits or other organisations supporting people, we really have this no wrong door. We have on the website, you can see the link around the service inquiry. Obviously, people can make a call through to the National Dementia Helpline. They can email regular contact. And I know, as Liz said, we get a significant amount of our referrals from the CADIS clinics in Victoria, or you can contact any of our offices to make a referral. Again, this can be a referral from a service provider. It also, we can have individuals sign up to get involved, and we'll have discussions around intake, around triaging whether someone's appropriate to participate in this. So what are our clients saying? So twice a year we look at surveying our clients in terms of their service experience and how we're improving any opportunity for health outcome and improve quality of life. So at the moment, in this initial first 6 to 8 months, we've said 80% of the people that were surveyed said the information and support they received was helpful. 75% said their understanding of dementia improved. 73% said they know how to access materials and resources, and 71% said they know how to access the supports they need. And just lastly, we had some commentary from our clients that have been involved talking about how it was very, the information was easy to understand, clearly delivered, and we absolutely follow up with, you know, information in writing, and we're working with individuals to set a goal. So the early signs of the program are quite promising, and we look forward to really growing the program from strength to strength.